Ladies and gentlemen, I'm Masanori Abe from Nihon University in Tokyo, Japan. I'd like to thank the chairman, Professor Davenport, for inviting me to speak here today. I'll be talking about super high flux dialyzers and mortality in hemodialysis patients. This is my COI. Today, I'll focus on what type of dialysis membranes should be used. I'll compare the effects of the different synthetic dialyzer membranes on mortality, as well as the relationship between dialyzer classification and mortality. The KDOQI guideline advises against the use of poorly biocompatible cellulose membrane, whereas the European guideline recommends using highly biocompatible high-flux membranes with large pores to decrease morbidity and mortality, and avoiding dialysis membranes that strongly activated complements white blood cells and inflammatory responses. Meanwhile, the Japanese Society for Dialysis Therapy, JSTT, recommends use of high-performance membrane, HPM dialyzers. Researchers have recently reported that beta-2 microglobulin, beta-2-mg, is not only a uremic toxin that should be removed, but also a predictor of prognosis in patients on dialysis. 1 year mortality was compared between a group with a beta-2-mg level of less than 25 milligrams per liter and a group with a level of 30 milligrams per liter or higher, using a group with a pre-dialysis beta-2-mg level of 25 to 30 milligrams per liter as a reference. The mortality rate increased with increasing pre-dialysis beta-2-mg level. Therefore, a higher pre-dialysis serum beta-2-mg level was associated with mortality. The recommended dialysis conditions are intended to achieve a maximum pre-dialysis beta-2-mg level of less than 30 milligrams per liter in Japan. Furthermore, decreasing the concentrations of substances larger than beta-2-mg may improve prognosis. To achieve this goal, we must consider the dialyzer. This is a Japanese classification for dialyzers. Type 1 dialyzers are classified as low flux, types 2 as low or high flux, type 3 as high flux, and types 4 and 5 as super high flux. HPM dialyzers are defined as having high hydraulic and solute permeability, particularly for middle molecular weight molecules and uremic toxins with a molecular weight of 10,000 to 30,000 Daltons, high biocompatibility, and a beta-2-mg clearance rate of more than 50 milliliters per minute. These dialyzers target uremic toxins of a relatively high molecular weight that cannot be removed by conventional dialyzers. The pores in these membranes are larger than those in high-flux membranes, which means that HPM dialyzers can remove small, medium, and large molecules, including low molecular weight proteins and small amounts of albumin. The optimal pore size should prevent loss of more than 3 grams of albumin per session using the standard hemodialysis procedure in Japan, which includes a blood flow rate of 200 milliliters per minute and a dialysate flow rate of 500 milliliters per minute. In Japan, the concept of the HPM or super high flux became popular in the early 1980s. The HPM was originally developed to eliminate middle molecular weight substances which previously could not be eliminated by cellulosic membranes. So the main purpose of the HPM came to be eliminating uremic substances with a molecular weight of 10,000 to 30,000 Daltons. As shown in this table, low-flux dialyzers are defined by an ultrafiltration rate of less than 20 milliliters per millimeter mercury per hour and a beta-2-mg clearance rate of less than 20 milliliters per minute, while high-flux dialyzers are defined by an ultrafiltration rate of 30 or more and a beta-2-mg clearance rate of at least 40. However, before 2016, dialyzers in Japan were classified as types 1 to 5 based on beta-2-mg clearance rates of less than 10, less than 30, less than 50, less than 70, and greater than 70 milliliters per minute at a blood flow rate of 200 milliliters per minute and a dialysate flow rate of 500 milliliters per minute. Types 4 and 5 are classified as high-performance or super high-flux membranes and are used for more than 90% of hemodialysis patients in Japan. Another classification was recently proposed as shown in this table. Dialyzers are now classified into 5 categories: low flux, high flux, medium cutoff, protein leaking, and high cutoff. In Japan, type 4 and 5 dialyzers or super high flux dialyzers correspond to the medium cutoff or protein leaking category. There are 7 types of HPM dialyzers in Japan. However, there is little information available regarding which type of dialyzer results in the best prognosis. Therefore, we conducted a cohort study using data from a nationwide registry of hemodialysis patients in Japan to determine the association between the different types of dialyzers and the 2-year all-cause mortality. The study population consisted of patients on maintenance hemodialysis between 2010 and 2012. Overall, 309,000 patients were registered as of the end of 2010. After exclusions, data were available for 136,000 patients. The patients were divided into 7 groups according to the type of dialyzer membrane material used. The clinical characteristics of each group are shown in this table. Patients treated with EBAR were older and more likely to be female and have a shorter hemodialysis duration, a higher cardiovascular comorbidity rate, and poor nutritional status. On the other hand, PS and PES membranes were associated with younger age, male sex, lower rates of diabetes and cardiovascular disease, CVD, and higher dialysis dose, NPCR, and percent CGR. As shown in this figure, after adjustment for nutrition-related and inflammation-related factors in addition to basic factors and dialysis dose, the hazard ratios were significantly lower for the PES and PMMA groups than for the PS group, with respective values of 0.88 and 0.84. This table shows the patient characteristics and baseline data in the PS group and each corresponding group after propensity score matching. There were no significant differences in any variables between the PS groups and the CTA, EBAR, and PAN groups, or between the PS group and PEPA, PES, and PMMA groups. Here are the results. There were no significant differences in hazard ratios between the CTA, EBAR, and PEPA groups and the PS group. The hazard ratios were significantly lower for the PMMA and PES groups compared with the PS group. Our findings suggest that the type of membrane used may affect mortality. Further long-term prospective studies are needed to clarify whether the PES and PMMA membranes can improve prognosis. Finally, I'd like to discuss dialyzer classification and mortality in hemodialysis patients. Dialyzers are classified as low flux, high flux, and protein leaking internationally and as types 1 to 5 based on the beta-2-mg clearance rates in Japan. Type 1 dialyzer corresponded to low flux dialyzers, types 2 and 3 to high flux dialyzers, and types 4 and 5 to super high flux dialyzers. In this nationwide retrospective cohort study, we aim to clarify the association of type of dialyzer with mortality by analyzing data from the JSDT Renal Data Registry from 2008 to 2011. We enrolled 242,000 patients on hemodialysis and divided them into type 1 to 5 groups using the Japanese classification. We assessed the association of each group with 3-year all-cause mortality and performed propensity score matching analysis. Most patients received hemodialysis with a type 4 dialyzer, 81.2%, followed by type 5, 12.3%, type 3, type 1, and type 2. Patients treated with the type 1 dialyzer were older, more likely to be female, to have higher rates of comorbid CVD and diabetes, and to have a lower BMI. In contrast, patients treated with a type 5 dialyzer were younger, more likely to be male, to have lower rates of comorbid CVD and diabetes, and to have a higher dialysis dose and higher NPCR and CGR. Kaplan-Meier analysis showed that survival deteriorated steadily from dialyzer type 1 to 5. After adjustment for basic factors, dialysis dose, and nutrition and inflammation-related factors, the hazard ratio for the type 3 group did not differ significantly from that for the type 4 group, although type 1 and 2 groups had significantly higher hazard ratios, and the type 5 group had a lower hazard ratio. This table shows the patient characteristics and baseline data in the type 4 group and each corresponding group after propensity score matching. There were no significant differences between the type 4 group and the type 1 and type 2 groups, or between the type 4 group and the type 3 and 4 groups. Compared with the type 4 group, the hazard ratio was significantly higher in the type 1 group and significantly lower in the type 5 group. Type of dialyzer classified by the beta-2 Mg clearance rate was significantly associated with 3-year mortality in this study. Our findings indicate that super high-flux dialyzers might be beneficial for patients on hemodialysis. Although type 4 and 5 dialyzers are both classified as super high-flux dialyzers, this study indicates that type 5 dialyzers are superior in terms of performance. To confirm the reproducibility of our findings, we performed a cohort study that analyzed data from the JSDT from 2010 to 2013. We performed 2 subgroup analyses. First, the dialyzers were classified as low flux, high flux, and super high flux dialyzers using the international definitions. Next, the dialyzers were classified as types 1, 2, 3, 4, or 5 based on the beta-2 Mg clearance rates according to Japanese classification. Type 1 dialyzer correspond to low flux, types 2 and 3 to high flux, and types 4 and 5 to super high flux dialyzers. We enrolled 238,000 patients on hemodialysis in this study and assessed the associations of each group with 3-year-old cause mortality after propensity score matching. This table shows the patient characteristics of each dialyzer group based on the international classification. Most patients received hemodialysis with super high flux dialyzers, 95.6%, followed by high flux and low flux dialyzers. Kaplan-Meier analysis showed that survival deteriorated steadily as the type of dialyzer increased. This figure shows the adjusted hazard ratios for all-cause mortality in each group. After adjustment for basic factors, dialysis dose, and nutrition and inflammation-related factors, the low flux group had a significantly higher hazard ratio of 1.12, whereas the super high flux group had a lower hazard ratio of 0.95. Patients treated with high flux dialyzers were matched with those treated with other types of dialyzers in a 1-to-1 ratio according to propensity scores. Compared with the high flux group, the low flux group had a significantly higher hazard ratio. However, the super high flux group had a significantly lower hazard ratio. This table shows the patient characteristics in each dialyzer group according to the Japanese classification. Most patients received hemodialysis with type 4 dialyzers, 74.3%, followed by type 5, 21.3%, type 3, type 2, and type 1. Kaplan-Meier analysis showed that survival steadily deteriorated as dialyzer type increased, except for type 5. The mortality rate was significantly and consistently lower in the groups with dialyzers providing higher beta-2 Mg clearance. This figure shows the adjusted hazard ratios for all-cause mortality in each group. After adjustment for basic factors, dialysis dose, nutrition, and inflammation-related factors, the hazard ratio was significantly higher at 1.1 for both type 1 and 2 groups, and significantly lower at 0.91 for the type 5 group. Patients who were treated with a type 4 dialyzer were propensity score matched with those treated with other types of dialyzers in a 1-to-1 ratio. As shown in this figure, there were no significant differences in the hazard ratio between the type 4 group and any of the other groups. However, the hazard ratio was significantly lower in the type 5 group. In summary, today I discussed what type of dialysis membrane should be used. The JSDT recommends the use of super high flux dialyzers. PES and PMMA membranes may improve prognosis, but long-term prospective studies are needed to clarify whether this is the case. Super high flux dialyzers, which include type 4 and type 5 dialyzers, might be beneficial for patients on hemodialysis. Our research indicates the superiority of the type 5 dialyzer, and further large-scale randomized control trials are needed to confirm this. Thank you for your attention.